patients and physicians will realize that they can do so much better for each other if you remove all the insurance barriers.
Today on the podcast for Doctors by Doctors, we are joined by Dr. Christopher Garofalo, who's a family medicine physician in North Attleboro, Massachusetts, including OB, and co-owns his private practice alongside 4 physician partners. Dr. Garofalo is deeply active in physician advocacy, both at the state and national level. Nationally, he serves as an AMA delegate for Massachusetts and is a member of the AMA Private Practice Physician Section. In Massachusetts, he sits on the House of Delegates, serves as treasurer in his district, and is a member of the Committees on Finance and Legislation and the Board of Trustees. For the past 8 years, he has chaired the Committee on the Sustainability of Private Practice, working to build and protect an environment where physician-owned practices can thrive. Welcome to the podcast.
Thank you very much, Michael. I appreciate being asked, and it's really an honor to be here with you, so thank you.
Absolutely. So, and even the listeners who heard your introduction know how much extra work you put in to really push the ball forward for physicians and practices. Can you tell us a little bit about, A, how do you have the time to own a practice and do all this extra work? But what really drives you to make sure you're advocating for doctors and their practices?
So I have the time to do this because, as you mentioned, I have 4 physician partners who we all own the practice. I don't know that I could do this if I was a solo owner. I really don't. So they are all really wonderful, and we all sort of divvy things up within the practice itself. So we all, we don't have to wear all the hats. We just have to wear some of them. And one of the ones that I think that I, like I say, that I wear for the practice is I advocate on our behalf. So that's part of what I do. I'm always talking to them about, I have a meeting coming up, or I'll be meeting with the Division of Insurance, for example. What issues do you have in the past week with prior authorization, so that I can bring some very specific issues to them? And of course, I have my family who's very supportive. My wife is also a family physician. She owns her own direct primary care practice, and she is very supportive in my advocacy. She doesn't have any interest in doing the advocacy, but she's very, very supportive in allowing me to do this. So, and I would say I came to advocacy years ago. I came a little late. In the AMA House of Delegate, it's really interesting. You see people who are my peers, who are my age, mid-50 range, and a lot of them have been doing this since they were medical students and residents. I didn't come to this until about 12 years ago, and I got really frustrated with seeing the way that medicine was going and seeing how tough things were for patients and physicians. And I actually said one day, I need to do something about this. So I answered an email for the Medical Society in Massachusetts. I showed up at a local Bristol North, which is my local medical society, a Bristol North meeting as a House of Delegates, and they elected me as a delegate, and I've moved on ever since. And I tell people, if it wasn't for the advocacy that I do, I don't know that I would have stuck within medicine for as long as I have, because as frustrating as this can be, it's really very rewarding.
Wow, that's really great. I think one of the big things that I thought about there is just showing up. Just showing up in and of itself presented opportunities that you wouldn't have known about before. And then that was half the battle. And then after that, it really became, it sounds like, more tangible on what you could do. But if you're not showing up, it's really, I think, a little opaque for those on the outside to even see how they can make a positive effect.
It really is. And one of the things I'll say is recently, the Division of Insurance in Massachusetts, maybe in the winter, held a couple of listening sessions. And one of those listening sessions was about prior authorization. What can the Division of Insurance do to help physicians with prior authorization? And some of your listeners may have heard that this very month, the governor in Massachusetts came out with some new revised regulations around prior authorization. Now, this isn't going to fix everything. But, for example, we are not going to have to get prior authorization for medications for diabetes, asthma, and congestive heart failure. So, the GLP-1 meds that I now have to get prior authorization for my patients with diabetes, I won't have to do that. We'll still have to do it for obesity and weight loss, but not for the stuff that we really shouldn't be doing it for. So that's sort of one of the very tangible ways that you actually really can have a difference, because they came to us and said, how can we do this better? And they listened to the physicians and they made some changes.
That's great. I'd love to know more about your story post residency and how you came to become a practice owner. Was that something that happened right out of the gate? Were you employed and then moved to private practice? Tell us a little bit more about your journey.
Thank you. Yeah, good question. When I first came out of residency, so first of all, I graduated from University of Massachusetts Medical School in the center of the state in Worcester, and then I did my family medicine residency at UMass as well. And then I went looking for a job, and I actually was hired by a hospital system down here in Attleboro, and it's called Sturdy. It was called Sturdy Memorial. Now they're Sturdy Health. And I worked in their office, family medicine practice, with a couple of other internal medicine physician, family medicine physician, and a rheumatologist. So it was sort of a mixed practice. And I worked there for 5 years. And every year, so when I came down here, I needed a new primary physician. And I said, well, I really don't want to have a physician at the hospital where I'm at. And I looked around, and there was this private family practice. And I started going. And the first couple of visits that I had with my primary care physician, he said, you're a doc. He said, you're working for Sturdy. He's like, why aren't you doing private practice? And I said, it's hard to do. And it's, he said, I'm doing it. He said, listen, when you get tired of working for Sturdy, you come and let me know. And 4 years later, I went in for my annual checkup, and I said, so is that offer still on the table? And he said, yes. So I went and I got hired by him. I left Sturdy. It was just time to move on. It was time to leave. And I'll be honest with you. I'll tell you the story why. At that time, we were seeing a huge influx of new patients, because this was right around the time of Romney Care. And our office was sort of the outpatient center for the hospital for family medicine. So any patients that came in through the emergency department who didn't have a primary care physician got funneled to us, which was great, in trying to take and build a practice. Well, I had built a practice over years, and now it was getting kind of tough, and we're seeing all these new patients, and I started having to push patients who have diabetes. Well, maybe they can't come in every 3 months. Maybe they can only come in every 4. And it started to get a little frustrating, and I went to the chief financial officer at the time at Sturdy, and I said, hey, we got an issue here. I'm having a lot of trouble getting my old patients, my established patients in, as well as meeting the needs of all these new patients who need care. And he said, some care is better than no care. And I tell this story all the time, and I left that meeting and I said, I need out, because that's not true. I didn't buy that at all. Some care is not better than no care. And what he meant was some of my previously established patients may need to wait longer for their care so that we can take on new patients. I left. I have now worked in primary care in the new office as family medicine, and I am in private practice. We own the practice. At that time, there was one owner, and then he gradually brought people on sort of one at a time, and it's been really good. It took about 5 or 6 years to really become partner, because I just wanted to work there for a little while. I wouldn't do it any other way now. I
love that story. I also love, again, you advocated for yourself, at least, and the patients, quite frankly, in that meeting with the CFO, and it's, I think, yielded, sounds like, a lot of positive effects on your community and your patients. I'm curious because, we talk to a lot of early career doctors, residents, fellows, et cetera, and it's almost like a foregone conclusion that you're going to be employed. And interestingly enough, if you look at the dental side, so the ADA put out a survey recently where essentially 92% of dental school graduates in their first 10 years of practice, 92% will be employed. Most of them actually end up going and owning a practice later in their career, but that's different for at least the dental side. Even the dental folks are becoming employed earlier. How do you see the future of practice ownership for early career physicians?
So we have seen a seismic shift in practice ownership just in general amongst all physicians. It's gone from about 75% down to about 25% depending on whose survey you listen to. And that's over 10 years or 15 years or so. That's a huge drop. And there's a lot of reasons for that, which I suspect we'll sort of talk about in a little bit. But I do see the pendulum starting to swing. I've talked to some people who feel that not only is the pendulum starting to swing from a physician side, with physicians coming out of residency wanting to own their own practice and be independent, but also from a systems side. There's a lot of rumblings around the hospitals and the systems. They realize they don't manage outpatient practices very well, particularly primary care. I think some of the subspecialties like surgery, especially where you're a procedure oriented and you're really more intimately tied to the hospital, that may be different. But as primary care, they just don't manage primary care well. And, they always talk about taking a loss on primary care. We're a loss leader. And, but that doesn't take into account the money that, as a physician, that we send to the hospital. Yeah, sure, I may not necessarily make all my salary back, but I send my patients for their imaging, I send them to the subspecialists, I send them to the lab. However, that is still not enough, and these hospitals and these systems are really having a hard time. So I do think there is going to be a shift. Part of the shift is going to be a direct primary care or direct specialty care, where they will not take insurance. They will see patients for sort of fee-for-service subscription model. That's a little hard to do as a physician coming just out of residency, but I still think it's going to be a lot more common because we're seeing a lot more established physicians do it. Because the insurance companies, the insurance model is just getting so difficult. It really seems like every other week the insurance companies do something else that basically the message to particularly primary care, but all physicians, is we're not interested in having you. And I know they're not saying that, but every time they put out, we're going to cut your reimbursement, or we're going to start auditing your charts more, or we're going to start downcoding using AI. I mean, it's like, I don't know how they think physicians are going to act to that, but physicians follow markets just like they do. And when it gets to be too difficult, physicians walk. And that's one of the things that I think is really important about having a private practice environment. And I tell my physicians, my friends who are employed, they say, why should we have private practice? I say, well, do you really want to have the choice of going from one really bad system employed to another system employed? No. Part of our ability to have some leverage is to have choice. And having a private practice environment is choice. Whether that's you own it as a solo, whether you join me in my practice with my 4 partners, even if you're not a partner. Yeah, you'd still be employed, but man, you're so much better off employed by 4 physicians rather than being owned by a system.
And it's choice of employment or work on the physician's behalf. It's also giving the patient's choice, which are unfortunately so limited depending on where you live and what your insurance is.
Yep.
I'm going back to the direct primary care piece because I would love for you just to walk us through the basics in case there are people listening that have heard it but don't really understand what the term means. So that's one thing. The next, I would love to hear how you counter that it might not be good from a society perspective because it cuts a lot of people off regarding access if they don't have cash to pay.
So first of all, conflict of interest. As I said before, my wife is a direct DPC owner. She actually worked for our practice. She's a family physician, and she was actually employed by our practice part-time. And 3 years ago, she left, not for any reason other than she couldn't do the insurance stuff. She said, I can't do this anymore. And she opened her own direct primary care practice. So what the idea is you have a physician. Oftentimes it's a solo. My wife is literally the only employee in her office. She shares an office with another physician who does DPC. That physician does have a medical assistant, but that medical assistant was with her when she was employed. She could probably not necessarily need her, but there's a relationship there that really works for them. My wife left, set up her own business. Basically, she gets patients to come to her. They pay a subscription fee, sort of, Average cost for direct primary care is about $85 a month. Direct primary care is different than concierge. Concierge medicine is where you pay typically a much higher fee per month, and the insurance company is still getting billed by your physician. Direct primary care, they don't have anything to do with your insurance company. My wife is not in the insurance company roles at all. She doesn't take Medicare. She doesn't take anything. And those patients can get unlimited, essentially, primary care. And you have to be able to offer a lot. There are some docs in Massachusetts in particular that I'm friends with who they do joint injections, they do suturing. I mean, they act as an urgent care. So they can take care of their patients, and they can prevent their patients from having to go to places like urgent care. One of the ways places like my wife who does that, or other DPC practices, is you've got time. You don't have 15 minutes. You can spend an hour. You can spend an hour and a half with patients. And when you can spend that amount of time, you can figure out diagnoses. You don't have to say, oh, I don't know, I heard a murmur, but I don't know what it is, and I'm just going to send you to the cardiologist. And you can work on their treatment more with them. They don't need to necessarily just get treated and streeted, as they say. And you can see them for the little stuff. You can see them for their colds. They don't have to go to urgent care because you can spend time with them, and they have access to you.
Yes.
They don't call up and your first appointment is 3 weeks out. And even in our office, one of the things we pride ourselves in our office is, we keep a few appointments open up every day so we can see patients. And I can't tell you over the past 3 years how grateful patients say, thank God you got me in today. I'm so happy. Patients will use urgent cares if that's what's available to them, but they really would rather not, and you probably see that in med peds, especially in primary care. They don't want to go to the urgent care, whether it's staffed by a physician or an NPP. It doesn't matter. They want to see you who knows them.
That's right.
You did ask about the sort of the downside, and I acknowledge there is a downside. However, I would counter that I actually think access is a different issue. Most patients can afford $85 a month. They're spending that on their Starbucks. They're spending on it, in other ways. That's not a judgment on these patients at all. But the reality is even patients who are on Medicare or Medicaid can, for the most part, come up with that because they end up saving money elsewhere. So, for example, most people now have really high deductible plans. Well, if your high deductible plan is $6,000 a year, almost nobody meets those deductibles. So you never get your care paid for. But if you come to see a DPC physician, you get your visit, you can go down the hall and get your lab done where a CBC is $5, your cholesterol panel is $10, as opposed to a cholesterol panel being charged by your insurance for, $200. You may only pay $50 of that, but you're paying more for that. Same thing with imaging. You can get a CT scan for a couple $100 if you pay cash for it. Well, patients would rather pay $2,000 a year to their primary physician and to their lab and their imaging rather than have to pay that to their deductible. So high deductible plans have made it a lot more easy for patients. And one of the things in Massachusetts, it is a little tough because there is such a highly concentrated insurance market. And as you probably know, in Massachusetts, you have to have insurance. Other parts of the country, there are people who go without, they don't have insurance. So their only care is to pay cash. Well, how are you going to do that? Are you going to go to a hospital system where, again, you're going to pay their rates that are inflated because they can't charge different rates to different people, right? They have to charge the same rate to the person who pays cash as the person who pays insurance. DPC, you don't have to do that. But here's the issue with some of this. My wife went from a panel of 1,500 patients to 150. That is where the issue with DPC and access is all of a sudden if more people went to DPC, you're going to have a lot more patients who don't have physicians. That is an issue. It's a very valid concern, and that does need to be worked on. Cost, when you really sit down and think about it, and you can talk to anyone who does DPC, People are willing to pay for what they value. And if you value time with your primary care physician, people will pay for it. That doesn't mean everybody can, and there will be some people who will be left behind. But a lot of those patients who are getting left behind are already left behind. They can't pay their co-pays for their meds. That's the other thing. In direct primary care, a lot of physicians will buy meds at wholesale price. So you can get your meds for pennies on the dollar as opposed to trying to get it from the pharmacy.
There's a lot of benefits. I have, I think you said the pendulum swinging. I think there's a lot of reasons why, back towards practice ownership. One of those is disgruntled employed physicians who want more control over their schedule and more control over how they see patients. And if the choice, and this is a false choice, but if the choice is cutting back or leaving medicine or being able to practice on your own, that's obviously better for access, right? Because that physician is now at least seeing some patients on their terms as opposed to leaving it all together or taking a non-clinical role. So there's a lot of benefits. I would love to hear your perspective, just given your history and advocacy, on where you think, if you had a time machine, you could go back to 1996 instead of 2026. What are some advocacy things you would have prioritized that you think could have prevented some of the consolidation and decrease in practice ownership that we've seen recently? Like, what are some of those things that happened that you think could have maybe been prevented?
I think one of the biggest things would be a lot of states, in fact, most states, have laws against ownership of practices by non-physicians. And we have seen a huge rise in groups like private equity that own these practices. Now, the way they get around that is they say, well, we have Dr. So-and-so here, and he owns that practice. Except PE really calls the shots. So how does that happen? All these states have laws preventing this. Well, laws are only as good as what the state is willing to enforce and what the people who will run the state are willing to enforce. There needs to be better enforcement. And if I could go back all that time, 30 years ago, if we had legislators and regulators who were willing to stand up and say, no, we are not going to allow you to vertically integrate. No, we are not going to allow you to consolidate. That would make a big difference because we would have more competition right now. And that would make it easier for physicians and for patients. So that's one thing. The other one is preventing the vertical consolidation, where you can have a health insurance company that owns the urgent cares, that owns the physicians, that owns the pharmacy, that again, we have laws that operate against monopolies, but we don't get those enforced. Now, fortunately, out in Oregon with Peace Health, we just saw Oregon's private equity law hold up. And they said, no, you, Apollo MD, I don't know how much your listeners know about this, but an emergency physician group was basically cut out of a contract, and they were going to bring in a PE group from Atlanta. And basically they sued and said, the law said, nope, you can't do that. So we're starting to see some of this being upheld now, and that's really nice to see. And I think we need to continue that. And I honestly think this is time some of these really integrated groups need to be broken up. And if they had not been allowed to get together back then, I think that would be a much better system for patients and physicians. Because every time, we've seen it in the Boston, Massachusetts market. Every time someone comes up, they say, well, we want to consolidate. We will save you money. We will make better care. And you look at them, and 5 years later, they haven't saved anybody any money, and they haven't saved anybody any better care. So, how many times do you have to do that until people say this doesn't work? All the data tells you it doesn't work, and everybody knows that. There has to be the political will and the legislative will to say no, which, again, is hard to do for lots of different reasons.
Yeah. I think most people would probably be surprised to know that insurance companies are some of the largest employers of physicians, unfortunately, in this country. And the laws, as you mentioned, but laws against doctors owning hospitals, which also is a big barrier. I mean, if attorneys can own law firms and plumbers can own plumbing businesses, why can't doctors own hospitals? And I mean, I understand the arguments against it, but I think it's played out.
I agree, and that was one other thing. I was going to mention that too as part of what I would change. You know, the ACA law had a lot of good things in it, and physicians and patients really benefited from that. But making physicians not be able to own hospitals, not be able to own surgery centers, has been a definite downside of that. And again, I get it too. Physicians have self-interest. They want to, they're just going to keep patients in beds. But, I don't know who thought that big corporations wouldn't do the same thing.
Are they not self-interested either? Like, that's literally the reason they exist.
Exactly. I don't get that. And, I think some of this is there's a presumption that physicians are rich, greedy people who are there just to take money from patients. And, you'll find that anywhere. But I think when you allow that perception to sort of drive your policy, when that really isn't what the data shows, that becomes a problem. And when those myths get put into policy, that's what harms patients. It's what harms physicians. And that's what led to preventing physicians from owning hospitals. And I think if you allowed physicians to own outpatient centers in hospitals, I think you'd see a very big difference. Those physicians are interested in taking good care of patients. You don't go into this business, you don't go into this profession to not do that. Are there bad apples? Yeah. Are there things we could do better? Absolutely. But you have to lead with the data. You have to lead with the information that you have. And that hasn't been done.
Yeah. I wanted to ask a question about direct primary care. I'll move off of it, I promise, eventually. But there has been some proposals of allowing insurance reimbursement for direct primary care subscriptions. So some plans say, hey, we'll actually reimburse for direct primary care. Do you think that ultimately undermines the model, or is that just an inevitable future for insurance companies to actually allow that?
There are some places, if there are some self-funded, for example, employers, and some of the direct primary care physicians will actually contract with an entire employer. They may bring 300 patients to the table, and that can be beneficial for both. Obviously, the problem is, as a physician, if you all of a sudden lose 300 patients, that's tough. But that is a model, and there's a lot of people in Massachusetts who are working towards that. They're trying to get these small employers who are being literally crushed by the healthcare costs. It's upwards now of $25,000, $30,000 a year for a family plan in Massachusetts. Employers can't afford that anymore. Employers can't afford to pick up half of that or 3/4 of that anymore. So I think if it's done right, I think, if you don't start doing, okay, every visit you get reimbursed and the physician has to send in a super bill every time, I think if the employer upfront pays X amount per month per employee, and those employees get all the care that they get, I think that sticks with the DPC model, and I think that still works. Now, again, I'm not a direct primary care physician, so you may hear different. But I think if you stick with the basics of the model, I think it works well in scaling it up like that.
It makes total sense. I'm curious, we talked a lot about primary care, private practice. And given where you sit and you're advocating and you're in these rooms really advocating for practice sustainability, which I'm very passionate about, that's one reason why we exist, to help support independent practices, is where do you see in the specialty, subspecialty space or surgical subspecialty space where there's going to be a renaissance or an increase in practice ownership? Are you seeing any trends outside of primary care that show increase there?
Yes. A lot of it is in the non-procedure specialties, endocrinology, rheumatology. I mean, rheumatology, they do some stuff, but, obviously I wouldn't, a joint injection is very different than needing a surgical suite for a cholecystectomy. But, nephrology, there actually is direct specialty care. DSC is becoming more common. I just had a physician who is in endocrinology, and she recently left a local practice in a neighboring state and was looking to rent space from our office. And she's going to open up her own direct specialty care office. So that is becoming more common. I think if you took the handcuffs off of the procedural specialists and because ambulatory surgical centers are part of that, you can't own that. You can only build on what you have. If you took the handcuffs off of that, I think you would see the specialty physicians who are procedurally related move more into the private practice space. However, I will tell you, there's a really good GYN doc who specializes in endometriosis care. He was in Waltham, part of a big hospital system, and he actually, about 6 months ago, made the leap and say, I'm going to leave the system and I'm going to go open up my own practice. I haven't had a chance to speak with him yet, but I have heard that he's going to be hiring actually another GYN to work with him. So it is happening, and I wanted to give him enough space to sort of do this at the start. It can be done. The physicians are doing it. They're realizing they can do it. And that's one of the things that I want our younger colleagues to realize because, like you said, they're just not exposed to this anymore. Everyone they work with works at the hospital. But we can do it, and we need to find some way to get that message out to them. But it is happening. It's dribs and drabs, but, just like anything else, it's going to hit a critical mass at some point. Because like you said, for a lot of physicians, the option is, I'm going to go work for pharma. I'm going to go work for someone else. It really is becoming a breaking point where physicians are just, I can't do this anymore. I'm burned out. Can't take good care of my patients. The moral injury experienced by physicians in taking care of their patients or trying to take care of their patients is really getting to a level that's unsustainable.
I agree. I love the work you're doing to try to support this effort, and I really feel very, very strongly that if we can financially support the doctors, and at least, obviously it's a very complicated issue, we're not going to solve everything at once, but letting someone be less financially stressed allows them to practice in the way they want to, and when a doctor can practice the way they intended and want to, patients benefit. We're not all doctors, but we're all patients. So this is kind of a public effort, I think, a public good effort as well. I'm preaching to the choir.
I think that's a really good point. I think one of the things is that in Massachusetts, they have floated an idea. They want to put a lot of money, it's several $1 million, into paying physicians' medical school tuition if you go into primary care. Now, it's interesting, the old is new, the new is old again. When I went through medical school, they actually had something called the learning contract. And when I went to UMass, I deferred 2/3 of my tuition. I paid 1/3, I deferred 2/3. If you went into primary care and stayed and practiced in Massachusetts after residency, that 2/3 of your tuition now was forgiven, essentially. The problem is that amount way back then, 30 years ago, was set at a certain level. It has not been addressed since then, so it's not as valuable to physicians nowadays. But I was actually talking to one of our Mass Medical Society advocates at the State House, and they said, oh my goodness, we're going to have this great program. And I said, whoa, whoa, whoa. I said, hold on. I said, let me give you another perspective. If you pay, let's say the average medical debt is $250,000, and half of that is forgiven or paid for by the system. Every medical student, every resident still knows that the delta between what they are going to make lifetime as a subspecialist versus what they get paid as a primary care physician, it's huge. So paying off medical school is not going to be enough. It may be helpful. So this sort of gets back to your point about how do we get patients to do practice. Well, I would contend those millions of dollars would be better spent as a loan or as a gift, something to set up patients in their own practices when they leave, rather than paying off their medical school. Because that's going to allow physicians to turn, it's going to help us to turn the tide. So that's sort of the point. It's not that we don't want to pay off medical school tuition. It's that can that money be spent better somewhere else? And I would contend that it could be. We need to find ways to put physicians into private practice.
Yeah, I mean, I think there would be a very interesting study, and I'm not sure if if it's happened, but there are schools that are tuition free now, and it'd be interesting. Has that changed the specialty that they've chosen? I don't think so.
No.
Yeah, so that's an interesting thought experiment to your point. I think some states like Florida have programs in which they will, I can't remember if it's a grant, but they have a program in which they basically provide some seed money for these private practices in areas of high need to facilitate choice and innovation and things like that.
I wasn't aware of that. That's interesting. I'll have to look into that. The AMA House of Delegates is meeting in Chicago in a couple of weeks, and I will see a number of my colleagues from Florida. I'll have to ask about that.
I'll be there. I'll be at the House of Delegates, and I'll be at the FMA meeting next week.
Oh, okay. Oh, all right. Great. Well, I'll have to look for you at HOD meeting. But you're right. Those are the kind of ideas that we need to really put forward if we want to encourage private practice, because that's, my wife and I, we took out a HELOC loan to open up her practice, which, was doable, but, it's not, first of all, not everyone can do that. And second of all, if, sometimes if you're going to have a bigger practice, my wife still sort of works part-time, her practice. And if you're going to be full-time, you probably need more to start with. So investing the money into physicians at that level is going to be really important.
Yeah, that's like one of the things that we have found helpful is if we're lending money for a startup, as an example, many times we mandate that some of those proceeds pay for a practice consultant. And so that way you're not doing it on your own. And some of our experience has been physicians are trying to have the smallest startup costs as possible. So don't pay anyone for the front desk. Don't pay anyone for labs. I'll do all my phlebotomy. And that then cuts down on potential revenue. But all that to say is it's worth it, I think, to have someone who has experience in the consulting world. Not everyone's created equal there, but in general to advise on some of the stuff that we're not trained on in our residency or medical school training. It more than pays for itself in my experience. So that also is a resource I think that's probably underutilized.
Agree. And I know there's a lot of people who advocate for, do we need to teach more business in medical school or in residency? And I used to think that would be really important and that would be a great idea. I'm not so sure about that. My wife has opened up a DPC practice. I mean, my wife is a very intelligent person, but she was not a business person. But she's opened and her practice is thriving without an MBA. So I think it can be done. Now, again, a direct primary care practice is very different than opening up a practice that's going to charge insurance. So that is a little bit more involved. But I'll tell you, we have literally across the block from us, my office in North Attleboro, there's a pediatrician who left Sturdy probably about 4 or 5 years ago and opened up her own private practice pediatric office, which is almost unheard of. And she is doing wonderfully. I don't know if she hired a practice consultant. I don't remember hearing about that. Even if she did, I mean, again, that's, it can be done. And she's doing it and loving it. And she didn't get an MBA. She hasn't gone to any little course like that. She did it all on her own. I'm not saying she didn't have help. I'm sure she did. Her husband is the office manager. He has a little more business experience. But it can be done, and you don't have to get an MBA. You don't have to spend $80,000 to get the MBA. But having, as you say, having a consultant, it doesn't have to be someone who's going to charge you 6 figures, but someone to guide you a little bit, I think is a really good idea.
And I think for doctors, we're generally smart enough to learn whatever we have time to sit and try to learn. The problem is we don't have the time. But once you are put on that path and you have a mentor, or you have a consultant, you kind of see what's possible, then I think you devote some time to it and we can learn it. I fully believe, kind of like we talked about, unfortunately in academic training, we're not given the opportunity to see the diversity in which you can practice and see patients. And some of that is obviously not on purpose, just the way the system is structured. But I hope the message, to your point, is getting out that there are options. And I think the trainees are starting to ask more questions about other possibilities. And maybe it's a combination of they want to pay off some debt initially, and then they get experience and kind of go do their thing. That's the analog in the dental space. That's what we're seeing right now. And I think something like that could happen here. The one thing I always think is fascinating is you mentioned 25% of physicians are in private practice or practice ownership, which of course is a steep decline. But what's so interesting to me is as an absolute number, that's more than all of dentistry. All dentists, regardless of practice scenario, yet we always talk about the entrepreneurs in the dental space as a percentage much higher, of course, but as an absolute number is less. And so I think but if you go to a dental school, industry is in a dental school, industry is in the residencies they hear from accountants, practice consultants. Not saying that's a good thing necessarily, but the exposure is there. Whereas in the medical space, I think it's just so alien at this point. We have a uphill battle on raising awareness. I'm on my soapbox. I realize I'm supposed to be interviewing you. Apologies.
No, I think you're right. I mean, we're supposed to be, we're not supposed to be business people. We're not supposed to be wanting to make money. We're supposed to be altruistic people who do this for the good of society. And we still do that. But, as I tell my patients, look, I got to keep the lights on. If I don't keep the lights on, I'm not helping anybody. And there is a fine line, and you can certainly sit down and debate. Do physicians make too much? Do they make too little? But the reality is that one of the things, my office, we have one person who we hire who does just prior authorization for our office. That's a 5-physician, 3 NPP practice. That money would be I love our person who does that, but she would be so much better off in a different role in my office if we didn't have to do that. The money is there in the medical system. It is just so maldistributed amongst, pick the ways, private practice versus facility fees for hospitals or systems, subspecialist versus primary care. It's such a maldistribution. It's there, but it's just not being put the way that we really need it to be.
Totally agree. I know we're rounding third and head to home. We end some of the interviews, well, actually technically all of them, with a rapid fire round. Essentially, I'll say a statement and I ask you if you think the statement is true or if it's false, in your opinion. I say rapid, it's almost exclusively not rapid, and we talk about all of them for an extended amount of time, but we'll try to be rapid. So, true or false, in 10 years, the number of doctors in private practice will be more than it is today?
True.
Why do you think so?
It's going to reverse itself. I think the more physicians are realizing that systems don't manage them well, systems don't do well, and physicians want their autonomy back. They can't continue to practice in the moral injury setting that many of these health systems set up for them. And they're going to find out that, I may think it's tough to open up a practice, but God, it's got to be so much better than what I'm doing now. I had a guy come in 2 weeks ago, 31 years old, doesn't have health insurance in Massachusetts because his job dropped insurance because it's a small business, and somehow he missed the window to sign up for insurance. But I've been taking care of him for 10 years. Now, he's 31. There aren't a lot of 31-year-olds who come in for a routine physical. He came into my office to get his annual checkup. And he said, what do I pay? And I gave him a cash price. I gave him a discount. And I said, come in, pay it, and we'll take care of you. He came in, paid it, took care of him. Patients and physicians will realize that they can do so much better for each other if you remove all the insurance barriers. And I know fee-for-service gets a really bad rap, but fee-for-service, the way people think about fee-for-service, really may not be the best thing. But if you literally bring it down to the sort of direct patient pays physician, physician services patient, that is fee-for-service at its purest. That works in a lot of ways. Not for everything, but it does work. And I think particularly in primary care, I think removing primary care from the whole insurance system is one of the ways that it's going to go. And I think that's partly why you're going to see a lot more physicians in private practice, because they will be unentangled from the whole web of system.
Yeah, that would be a crazy shift that I think ultimately patients would win. Next true and false statement. True or false, AI-enabled tools will make it easier to own a practice?
True.
What are some of those tools that make it easier?
AI tools make it easier by, helping to automate some of the stuff. So for example, if you can write your notes easier. First of all, if you are in a practice like a DPC practice, you don't have to write notes because you're not writing them for billing. However, you still got to put together a medical record, right? And if you can put together a medical record by having AI in your room listening to you and the patient, that will help. Using AI to make sure that medications get sent off for refills and things like that will be helpful. AI is not going to replace physicians, but physicians who don't utilize AI will go out of business. Just like physicians who have not utilized electronic medical records, they don't really exist much anymore. You really can't do that. So I think AI will be part of it. And I'm sure AI will also do things that we don't even think about yet. But I think, utilizing AI to reach out to patients, some of the automated systems now, reaching out to patients, checking in. My wife can set up a message to get sent out to a patient 3 days after her visit and say, hey, are you doing okay? How are things going? And I think some of that is going to be helpful.
I totally agree. Last true and false statement. True or false, you would choose family medicine today over any other specialty?
True. I can't imagine doing anything else. When I first started going to med school, I thought, well, maybe I want to be an ophthalmologist. I had done some eye research when I was an undergraduate, and I said, maybe I want to do this. And then I got to med school, and I really started to think about it, and I said, primary care is more my thing. I do better thinking about lots of different things at sort of not a huge depth, but I do much better with all these different things, a wide range of topics. And I love that because I can take care of my patient in that way. I can take care of most of what they need.
I'm the same way. Med peds, like I said, distant cousins of family medicine, have very similar personalities there. Well, I really appreciate this. We have one final question we ask every guest, and that is, what is one thing that you've recently changed your mind about? We're in the setting of more information than we've ever had access to, yet I sometimes find more information doesn't necessarily lead to more free thinking. It just reinforces our current thinking. So I like to ask, what's something that you've actually changed your mind about?
I have become more convinced that primary care needs to be removed from the insurance system. In some ways, I've always thought that, but I've been saying for years, and other people have said this too, when you fill up your gas tank, do you charge that to your insurance? When you replace your wiper blades, do you charge that to your car insurance? And everyone looks at you and goes, no. Well, that's what we're asking primary care to do. And we need to remove it. And I say to people, well, what if every time you filled up your gas tank, what would happen to your car insurance? Oh my God, it would go through the roof. I couldn't pay for it. That's what we have done with primary care. For a long time, I recognized that, but I thought, well, we can make it work. You change this, you change that. But the past 6 months, 12 months, I have become convinced that primary care, regardless of whether you are a DPC, concierge, solo, 6 people, is going to need to be removed from the insurance system as a whole in order to really save primary care.
I think we could do a whole episode on just that topic. I would love to dive deeper. I appreciate your time. I know you're a busy person. Where can listeners find you online or follow more about your work in advocacy or medicine?
It's interesting. I don't do a lot of social media stuff. I do a lot of stuff on Facebook. I am of that generation. When Twitter came out, X now, I looked at that. I signed up for it. I tried to do it. And I said, God, until someone can tell me how this is better than Facebook, I can't do this, I don't have the bandwidth, as they say. I can only do so much. So I'm on Facebook. I post a lot. I'm in a lot of the physician groups there. I'm on there on my name. People can find me. They can message me. I don't do LinkedIn. I mean, again, I have a profile, but I just haven't been on there. I know people talk a lot, oh, you should be branding yourself, this and that. I just want to take care of my patients and I want to advocate. I don't need to do that. But people can reach out to me. They can find me. You can look up where I practice. You can find me on Facebook. I do all my advocacy there. Or you find me, come find me in Chicago.
Okay, that's great. Well, Dr. Garofalo, thank you for your time. This has been very awesome hearing your perspective on things, and I'll see you here next week.
All right. Thank you very much. Take care.
Thanks for joining us this episode, and you can catch the podcast for Doctors by Doctors on Apple, Spotify, YouTube, and all the other major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. To submit topic suggestions or guest suggestions or questions, you can reach us at podcast@panaceafinancial.com. As always, thanks for listening, and the next time you see a doctor, maybe you should prescribe them this podcast. See you next time.